Hi everyone, can you please tell me if I am audible and visible both? Hi. Hi new concept. Can you please tell me if I am audible and visible? Okay. To introduce myself, I am Dr. Resham Vasani. I am an educator in the subject of dermatology on Unacademy, and I'm also an honorary consultant dermatologist at Navroji Vadia and the BJ Vadia Hospital for Children at Parel. I'm also a consultant dermatologist at Matunga, Mumbai. My core interest is clinical dermatology and pediatric dermatology. With that, I would like you to get introduced to the Plus subscription. The Plus subscription of Unacademy is where you get the daily live classes, live tests, quizzes, a structured course, and an unlimited access to all the existing courses as well as the previous courses on Unacademy. There is also an iconic subscription is where you have the best of prep ladder along with the best of Unacademy. So through Unacademy you have the live tests and the batch courses, and through prep ladder you have the video bank and the lecture series, live tests and quizzes as well as rapid revision courses. So also to let you know that there have been certain batches which have already started off on 15th of February, and there is a focus batch for FMGE which has started off on 15th of Feb, will go on up to 29th of May. There will be new batches every week with top educators in the field. There is a target next 2022 evening batch which is going to start off, which has started off in 15th of Feb, will go on up to July. And there is the last mile to crack NEET PG 2021 which started off on 15th Feb and will go on up to 20th of March. Also there is a test series which has started off. You can enroll for it. There will be daily test series which will be published, and there is a boost your clinical and allied subject skills to crack the NEET PG exam. The next is on February 27th where there will be a subject wide test on ophthalmology, ENT and pediatrics. So for that what you need to do is to download the Unacademy app that is available on your iOS and on your Android platforms. When you opt for the Plus subscription of Unacademy, that would cost you around for 12 months it will be 2063 a month, while when you take an iconic subscription it will be around 4125 for 12 months. And when you do use these subscriptions, please enter the code mentor. That is going to give you an additional 10% off on the subscription. Okay, so let's begin with the topic for today. The topic for today that I have decided will be basically focusing on bacterial infections. So I would like all of you to actively participate in this. Yeah, so you look at this picture and you have to identify the clinical type of tuberculosis which is seen in the image. Is it lupus vulgaris? Is it scrofuloderma? Is it tuberculosis verrucosa cutis, or is it lichen scrofulosorum is the question. New concept, can you please answer what is the correct option? Yes, new concept, you are completely correct. It is tuberculosis verrucosa cutis. Correct. So this is what tuberculosis verrucosa cutis looks like. It's a verrucous plaque on the foot usually. Okay, and as you can see this patient is having an MT positive. Okay, so tuberculosis verrucosa cutis is a variation of post primary tuberculosis or post primary cutaneous tuberculosis in a patient having good immunity, and because the patient is having good immunity the MT is positive. Okay, Now, differential diagnosis of plaques on the foot include tuberculosis verrucosa cutis, a verruca, and a con. Now, tuberculosis verrucosa cutis, usually the patient will give a history of a thorn prick, following which there was appearance of a verrucous plaque. In verruca, when you par the lesion, you will be able to see hemorrhagic spots, or you will be able to see thrombosed vessels. Hemorrhagic thrombosed vessels is what you will be able to see when you par a verruca. Verruca is basically a viral infection, and con, you will see that there will be a central core. Okay, that central core that you see in a con is like this. It is shaped like this. Okay, so the pointed end of that core is into the skin, into the pushing and jutting into the dermis. So that is why when you press a con vertically, there is pain, while when you press a verruca laterally, there is pain. So remember, the clinical way to differentiate a verruca from a con is that in a case of verruca, there will be pain which will be present on lateral pressure, while in a con there will be pain on vertical pressure. So also verruca, you will see that the normal skin linings which you see, they will be lost. Okay, so normal skin markings are completely lost in a verruca as well as in a con. That's how you differentiate it from a callosity. Callosity is thickening of the skin which happens because of chronic trauma or chronic friction. Okay, so in a con and a verruca, you will see the loss of normal skin markings, while in a callosity, the normal skin markings will be retained. Okay, but a verruca is going to be painful on lateral pressure, and a con is going to be painful on central pressure or vertical pressure. You will see thrombosed vessels when you par a verruca, and you will see a central core when you par a con. So, the most common variant of cutaneous tuberculosis that you see in skin in dermatology is lupus vulgaris. Now, lupus vulgaris, the word vulgaris itself means it is common. Okay, so vulgaris can be either endogenously acquired or it can be exogenously acquired, both. Okay, so there is inoculation of bacilli into the skin of a patient who is already sensitized, and hence the MT is strongly positive. It can be exogenous or endogenous, that is hematogenous. There will be a single plaque or grouped red brown papules which heals at one end and progresses to the other end. Okay, so this is something very, very characteristic for lupus vulgaris. There will be brown papules which will heal at one end and they will progress at the other end. Healing with scarring happens centrally. Face and buttocks are the common sites. It's a paucibacillary disease. Apple jelly nodules and diascopy are seen in lupus vulgaris. They are also seen in sarcoidosis, and they are also seen in leishmaniasis. So these are the three common causes of apple jelly nodules on diascopy. Okay. Then there is another test which is associated with lupus vulgaris, and that is the matchstick test. So it says that when you put a wooden matchstick on and it is pressed on the lesion of lupus vulgaris, the stick penetrates the thin epidermis easily, but it stands on itself without support on the firm dermal nodules. Skin biopsy will show you the presence of tuberculoid granulomas. Remember, there will be only a scant or an absent caseation, unlike the other tuberculosis of the lungs or of the kidney, and it will be culture positive in 1/3 of the cases. So this is what lupus vulgaris looks like. You have a margin which is active, which is actively spreading, and the center is going to heal with atrophy and scarring. Okay, so please remember, central clearing, okay, with associated itching you see in tinea. Central scarring You see it in patients with lupus vulgaris, and central crusting is what you see in leishmaniasis. Okay, so this concept has to be very clear. Central clearing in tinea, central scarring in lupus vulgaris, and central crusting is what you see in leishmaniasis. Now, what is scrofuloderma? Scrofuloderma occurs because of direct extension. It occurs because of direct extension from an underlying focus of infection, which may be a cervical lymph node, it can be a bone, it can be the joint getting primarily infected. So basically there is a focus of tuberculosis, and from that focus of tuberculosis there is suppuration, and then it opens out into the skin in the form of sinuses. So it begins as nodules which suppurate so as to form a cold abscess, and then it drains into non-healing sinuses. Then there is periorificial TB. Periorificial TB because of involvement of the orifices. Okay, so if the patient is having lung TB, he is coughing, he is going to push the Mycobacterium tuberculosis into the skin surrounding the mouth, surrounding the nose. Okay, whenever there is rectal tuberculosis, there can be perianal lesions. Whenever there is urinary tuberculosis, I mean whenever there is kidney tuberculosis, there can be periurethral lesions as well. Now skin immunity, since immunity is low, the bacilli proliferate freely and the MT is going to be negative. Now there is something which is called as tuberculids. Now these tuberculids are basically a hypersensitivity phenomenon. So basically they are daughter lesions on the skin from a primarily internal, often ignored silent focus of tuberculosis. It occurs in patients with strong immunity of tuberculosis, so the MT is strongly positive. So you have the micropapular variant, which you can see there are multiple tiny micropapular shiny lesions which are kind of grouped together, and if you see the Montu test, it is going to be strongly positive. And if you see the histopathology, this has been asked as a question to you. The histopathology will show non-caseating granulomas in a perifollicular location. So that is what you see in lichen scrofulosorum. In papillonecrotic tuberculid, you are going to see asymptomatic repeated crops of papillonecrotic lesions which are symmetrically distributed on the extensor aspects of the extremities like elbow, knees, hands and the feet. So it begins like a papule, then it forms a central crust, and then this central crust is going to heal with a scar. Okay, so that is papillonecrotic tuberculid. And then you have the nodular tuberculid, or also called as erythema induratum of Bézin. Okay, so here typical presentation is tender dusky nodules on the calf of a middle-aged woman, which often ulcerates. Okay, so you can see the ulceration in these lesions. It often ulcerates. On histopathology, typically you have lobular plus septal paniculitis with vasculitis. So when you have vasculitis, there is occlusion of the blood supply to that area, as a result of which there is formation of an ulcer. Okay, so that is in the erythema induratum of Bézin. Now let's go to the next question. Identify the sign shown in the picture. Is it the bulla spread sign? Is it the hypopyon sign? Is it the groove sign or the satellite sign? Anyone? Can anyone tell me what is the sign in the picture? Is it the bulla spread sign, hypopyon sign, groove sign or the satellite sign? Yes, correct. Very good, Amit. The correct answer is hypopyon sign. Okay, so this is the hypopyon sign. Yes, Alok, it is a bulla, but if you see a bulla, there is pus within it. Okay, and this pus is forming an air fluid level because it gravitates down. Okay, so this is the hypopyon sign. What is a bulla spread sign? Bulla spread sign is basically seen in subepidermal. Bulla spread sign, you can see it in both intraepidermal as well as subepidermal blistering disorders. So what you do in a bulla spread sign is that when you apply pressure to the bulla, So when you have a bulla and when you apply pressure to the bulla laterally, okay, then you are going to increase the tension within the bulla, right? And when there will be increase in the tension of the bulla will get extended. So you have to look out for the margin of extension. If you see that the margin is rounded, that means you are dealing with a subepidermal blistering disorder like bullous pemphigoid. And if you see that the margin is angulated, that means you are dealing with an intraepidermal blistering disorder like pemphigus group of disorders. Okay. Groove sign is seen in LGV. So bulla spread sign is seen in all vesiculobullous disorders. Groove sign is seen in LGV, that is lymphogranuloma venereum, in the inguinal stage when you have lymphadenopathy which is present above and below the inguinal ligament. The two swellings are kind of separated by the inguinal ligament and it looks like a groove, right? So groove sign is seen in LGV. Satellite sign, basically satellite lesions are seen in patients with borderline tuberculoid Hansen's disease. So satellite lesions are seen in BTH and that's why that's called as the satellite sign. And the hypopyon sign, as Amit has correctly mentioned, it is present in bullous impetigo, also called as pemphigus neonatum. It is caused by Staphylococcus aureus. So what this Staphylococcus aureus does is that it releases a toxin which is called as the epidermolytic toxin, and this toxin ruptures the desmosomes in the subcorneal layer because the target of this epidermolytic toxin is desmoglein 1. So there is a formation of a subcorneal cleft and this pus settles at the lower end of the blister because it is heavier, and that is called as the hypopyon sign. Now, in most of the individuals, this epidermolytic toxin is removed out from the body by the kidneys. But when it is not possible, like when the kidney is immature or if there is a kidney impairment, then there is likelihood that this epidermolytic toxin will disseminate hematogenously, and that will give rise to staphylococcal scalded skin syndrome. Okay. So on histopathology, you will see that there will be a blister which will be present below the stratum corneum because desmoglein 1 is present in the subcorneal location, and there will be plenty of neutrophils. Another variant of impetigo is impetigo contagiosa, which is also called as non-bullous impetigo. It is the commonest skin infection in children. The exposed sites like the face are more commonly affected. In warmer climates and in developing countries like ours, this particular infection is more commonly caused by streptococci than staphylococci. There is a very flaccid blister which ruptures, it forms an erosion and it is covered with honey colored crusts. The complication of this condition is that there can be post-streptococcal glomerulonephritis, okay, and the treatment is with, of course, antibiotics. So the classical feature that you need to remember here is the presence of these honey colored crusts. Okay, so there is a vesicle, but that vesicle is very transient. It becomes an erosion and this erosion gets covered with honey colored crusts. Let's go to the next question. Exfoliative toxins released by staphylococci are implicated in the causation of impetigo, ecthyma, erysipelas or staphylococcal scalded skin syndrome. I think we have answered this partially in the previous question. Can anybody write the correct answer? Yes, new concept, you are right. It is staphylococcal scalded skin syndrome. So as I mentioned, in patients who have infection by staphylococci, the staphylococci release the epidermolytic toxin. But in children who are less than 5 years of age, the kidney is not going to be efficient enough to remove that toxin from the body, as a result of which there is dissemination of the toxin hematogenously, and that leads to a staphylococcal scalded skin syndrome. Okay, so staphylococcal scalded skin syndrome, it's a blistering disease in the neonates and young children who are less than 5 years of age. Because less than 5 years of age, the body is not efficient enough to remove the toxin. So there is usually a focus of staphylococcal infection, which can be a furuncle, it can be otitis media, and then this particular infection and this toxin, it tends to spread hematogenously. So the patient is going to have fever, and following that the patient develops widespread blistering. Okay, that blister is in the subcorneal location. Why is there a subcorneal location? Because the desmoglein 1 is getting damaged. Okay, so you have a subcorneal blister, and then after that you can have erosions. You will also have a Nikolsky sign positive. So this is the Nikolsky sign. So Nikolsky sign, it is positive because you are dealing with intraepidermal blistering disorders. Remember, Nikolsky sign is positive in intraepidermal blistering disorders. It is negative in subepidermal blistering disorders. So Nikolsky sign is where you apply a shearing force, okay, to the adjacent normal skin surrounding a bulla. You will see that there will be peeling of the skin. Okay, so the skin will be completely, epidermis will be removed off. Okay, so that is called as the Nikolsky sign. As you can see, it is positive. Also, very characteristically, there will be perioral crusting and scaling. So this perioral crusting and scaling is something very classical for staphylococcal scalded skin syndrome. Remember, in patients with staphylococcal scalded skin syndrome, you will not see the involvement of the oral cavity. Okay, because in staphylococcal scalded skin syndrome, you have damage to desmoglein 1. There is damage to desmoglein 1, and this desmoglein 1 is going to be absent in the oral cavity. Okay, so absence of oral involvement, but there will be periorifacial scaling and crusting. Okay, histopathology will be similar to bullous impetigo. Now, this condition, look at the picture. It's a very classical picture. Okay, so look at the picture and you have to tell me what is this condition caused by: Streptococcus, Pseudomonas, Staphylococcus, or all of the above. A myth, new concept, alog, fun tube, anyone new? What is the condition that we are looking at in this picture? Okay, now the correct answer here is all of the above. So basically you are dealing with a patient who is having a hemorrhagic crust, which is adherent. Okay, adherent, and below that there is an ulcer. Okay, so this basically is fitting into the description of an ecthyma, right? So this ecthyma can be caused by Streptococcus pyogenes, it can be caused by Staphylococcus aureus, and Ecthyma gangrenosum can be caused by Pseudomonas aeruginosa. Okay, so the correct answer here is all of the above. So a thick hemorrhagic crust which is deeply adherent. When you try and remove the crust, when you see an ulcer, your diagnosis is ecthyma, which can be caused by, more commonly by Streptococci, can also be caused by Staphylococci, and Ecthyma gangrenosum can be caused by Pseudomonas aeruginosa. Okay, so this is the thick adherent crust that you need to remember. It is more common on the lower extremities in elderly patients, in diabetes, and in patients with poor hygiene. Let's go to the next question. Look at this picture and you have to tell me what is this condition caused by. Is it caused by Corynebacterium tenuis, Corynebacterium minutissimum? Is it caused by Micrococcus sedentarius, or all of the above? Yes, so Ali says it's B, New concept says it's D. Alok says it's D. First of all, tell me what is the condition that you are looking at, a brown colored patch in the axilla of a male. What is the condition? The condition that we are looking at is erythrasma. Okay, so it is erythrasma. Erythrasma is a corynebacterial infection which is caused by Corynebacterium minutissimum. Okay, so Corynebacterium minutissimum is the correct answer. Corynebacterium tenuis is going to cause something which is called as Trichomycosis axillaris. So remember, Trichomycosis axillaris is a misnomer. It's not a fungal infection, it's not a mycosis. It is actually an infection which is caused by Corynebacteria, and the organism is Corynebacterium tenuis. So Trichomycosis axillaris is the Corynebacterium which causes Trichomycosis axillaris. Micrococcus sedentarius causes pitted keratolysis. Okay, so pitted keratolysis is caused by yes, no problem, new concept, I understand that, but we are all here to learn. Okay, so erythrasma presents as well defined red brown patches in the intertriginous areas like the axillae and the groins. It is caused by Corynebacterium minutissimum. The investigation of choice is coral red fluorescence on Wood's lamp examination. So you can see here the reddish colored fluorescence that you can see. The coral red fluorescence on Wood's lamp examination is what you see in erythrasma. Let's go to the next question. This condition is commonly seen in people with prolonged contact with water, palmoplantar hyperhidrosis A and B, or plantar eczema. You can see that there are multiple pits, okay, in the sole, and these pits are kind of coalescing together and they are forming craters and large areas of denudation of the skin. So basically what is this? Yes, so this condition is nothing but pitted keratolysis. Pitted keratolysis can happen because of prolonged contact with water as well as palmoplantar hyperhidrosis. So the correct answer is C. Okay, so pitted keratolysis occurs because of infection by the Micrococcus sedentarius and the other corynebacteria, and basically there is it causes keratolysis. That means the stratum corneum is removed, as a result of which you get these multiple pits, and then these pits, they kind of coalesce together so as to form craters, and there is loss of skin. There may be associated burning sensation and itching on the sole, and this tends to happen because of prolonged contact with water and palmoplantar hyperhidrosis. Okay. Now, diseases caused by Pseudomonas aeruginosa includes all except, you have to tell me what does it not include. Ecthyma gangrenosum, hot tub folliculitis, tropical immersion foot, or bacillary angiomatosis. Alok Kumar, pitted keratolysis more commonly happens in the housemaids. Okay. That's because of prolonged contact with water. Yes, Ali, I agree with you. New concept, do not get discouraged. Okay, don't worry. Dermatology is a very, very interesting subject. Okay, you can come up. I am coming up with a course on Unacademy which will be starting from the basics of dermatology, which is kicking off from March. Okay, so you can attend that course. It will be great for people who have not yet learned dermatology. Okay, so the correct answer is D. As Shekhar, Ali, new concept, all of you are right. The correct answer is D. Okay, so diseases caused by Pseudomonas aeruginosa includes all except D. Ecthyma gangrenosum I already mentioned is caused by Pseudomonas. Hot tub folliculitis is also caused by Pseudomonas, and so is tropical immersion foot. Lichen planus is a curable disease is what Angel is asking me. Lichen planus, definitely one can give clearance to the patient as regards to the lesions of lichen planus. We can decrease the itching, we can take care of the elevation of the lesions. The pigmentation may also disappear with time, but the lichen planus is such a condition that can, in around 20% of the individuals, it can be a relapsing problem. One cannot predict the relapse, but definitely once there is a relapse, one can definitely improve the symptoms of the patient and make the patient much better, and we can also avoid the spread of the lichen planus to other conditions. Yes, folliculitis can be caused by multiple bacteria including Staphylococcal, Streptococci. Okay, but hot tub folliculitis, which is, when multiple people are using the jacuzzi, so it can cause, if it's not cleaned on a regular basis, it can cause the proliferation of Pseudomonas, and that can cause hot tub folliculitis, as you can see in this picture. Green nail syndrome is also one of the other conditions which happens because of Pseudomonas infection, and this is Ecthyma gangrenosum. Okay, so I think that's the time we have today. I will be having my next YouTube session tomorrow. Tomorrow between 4:30 to 5. Please be there. Tomorrow we'll be discussing a few other images which are important and which are high yield topics. Okay, so thank you everyone for joining in today. See you tomorrow. Bye. Angel Puja, you can definitely go for allopathy in lichen planus. Okay, I think that will be a very good treatment for lichen planus. Okay, see a good dermatologist. Thank you new concept. Tomorrow time fun tube will be between 4:30 to 5. Okay, pharmacology related skin conditions, you mean the drugs used in dermatological conditions, right? That's what you want me to discuss, right? Yes, we'll do that, don't worry. Okay, yeah, bye. I'm signing off for now. Bye.